So I hope everyone's seeing the disclosure slide. Let me know if you're not. Obviously, in medical education, we start every discussion about disclosures. I have served as an unpaid advisor to both Bernie Sanders and Elizabeth Warren's presidential campaigns. It's already a long time ago, and have collaborated on research with Elizabeth Warren. As I mentioned before, I'm a co-founder of Physicians for a National Health Program. I don't have any financial conflicts of interest. Okay, now I'm having trouble getting this to advance. There we go. Okay, it's advancing fine now. So, all right, I'm going to start with some material you may have heard before, but this is really in terms of framing what the problems are in American healthcare and why we do need some sort of change, either national health insurance, or we need to be thinking about the ownership question in National Health Service. And I think that was the topic that I'm supposed to focus on today, is why we might think about going beyond the traditional single payer approach of Medicare for all to think about who actually owns and controls the healthcare system. So that's something that's emerged recently as an important issue. But I want to start with talking about the underlying problems in the healthcare system, and why I and other people think there needs to be reform. We should mention the tremendous cost of U.S. healthcare. It's over $14,000 for every man, woman, and child living in the United States, an average of over $14,000 this year. That's actually a tremendous amount of money, even when we're talking about healthcare. And in fact, it's substantially more than the cost of healthcare in other nations on a as a percent of GDP or on a per capita basis. But here I'm showing it as a percent of GDP, which should be similar to per capita, right, for developed nations. Um, I've got the US in light blue, and I have other nations like Canada, France, Germany, and the UK in the other colors. And you'll see that around 1970, the US was, more or less the middle of the pack with other countries. Um, it wasn't that much higher. It was pretty much the same. About 6% of GDP was going to healthcare. Um, and health expenditures did rise as a share of GDP in those other countries, but you'll notice that the light blue line representing the United States has been rising much more rapidly than health expenditures in other countries. Now, we're not shocked that health expenditures in other countries rise, because as nations get more affluent, they often choose to spend more money on healthcare, or they can spend more money on healthcare. But it is rather shocking that the US is spending so much more than other countries that are similarly affluent to the United States. So that's one problem, not just that health expenditures are rising, but they're rising much faster than GDP and rising much faster than the average rise in other affluent nations. The other very serious problem is the lag in life expectancy. And you'll notice that other slide started in the 70s and 80s. This one starts in the 1980s. But if we look at the life expectancy in the United States here in red, and compare it to other nations, in this case, I think I've got 18 other nations on this slide, you'll see that, again, in the 1980s, US life expectancy was fairly similar to 18 other developed nations, other affluent nations. But then life expectancy did rise until about 2010, but it was not rising nearly as fast as the average of other nations. So despite spending more, having higher costs, higher share of GDP devoted to healthcare, a rising share of GDP devoted to healthcare, the United States was lagging behind in life expectancy. but if you'll follow that red line, you'll note that in about 2010, the line flattens out and there were really no major improvements in life expectancy in the United States after 2010, while life expectancy continued to go up in those other nations. The other thing you may see, it might be a little difficult because where the pictures are, but uh, is during the COVID pandemic, other nations saw a 1 year dramatic drop in life expectancy. Many nations like Italy and Spain were caught off guard, and France were caught off guard by the pandemic and had a very, steep drop in their life expectancy. But in the United States, not only did we have a very steep drop in 2020, but we continued to drop through 2021. And in fact, there were more COVID deaths in 2021 than in 2020 in the United States, which is unique among developed nations. The other developed nations kind of got things under control by 2021. So, and we've continued to have life expectancy way lower than other nations. Let's see if I can, okay. I can't see your pictures now, so you're going to have to shout at me if you want to say something. Okay. Okay, so in other words, our progress on longevity in the United States halted and really has not halted in other developed nations. Just going over a little bit longer time frame here, we're showing the increase in life expectancy in the United States through about 2010, the leveling off 2010 to 2019, the steep drop in 2020, 2021, and here I've just got 2022. Where we did see some recovery in life expectancy. There's been more recovery in 2023 and provisionally in 2024, but we're still way behind where we were in 2019 and obviously very, very far behind other developed nations. Let's see if I can get you back. Oh, okay. What happened here? Let's share again. All right. It says I'm screen sharing, so let me get you.
We can
Okay, I guess that's what I can do. I thought I was doing something else. Show small active speaker video. All right. Or grid video. Okay, that works for me. When it gets in the way, we'll just close it a little bit. It's a little easier if I see your faces. Somehow talking into the void is a little difficult. Yeah. Okay, so but even these sort of pretty abysmal life expectancy statistics hide like a much deeper problem in some populations. And I've recently been doing some work on Native American life expectancy, which is unbelievably bad. But Black and Native Americans die far younger than other Americans. It turns out Hispanics have similar life expectancy currently to whites. They used to have significantly better life expectancy prior to the pandemic. They were hit very hard by the pandemic, and I'm not sure it's fully recovered as of 2023. Asians have the longest life expectancy, but also in the United States, older Asians tend to be rather affluent. But Black and Native Americans who have a sort of very specific historical oppression in the United States still have a life expectancy that lags, many, many years behind everybody else, basically white, Hispanic, and Asian. And just to remind people that many Black people in the United States were descendants of slaves, even if they're not themselves descendants of slaves. Many were exposed to Jim Crow prior to the Civil Rights Movement. That is a legal discrimination that occurred in a lot of the South. And of course, there is obviously continued discrimination against Black people. Native Americans, the entire U.S. land mass was at one point Native American land. So these people were subjected to genocide, forced cultural assimilation. And the structural effects of that, the poverty, the lack of opportunity that Blacks and Native Americans experience continues to lead them to have by far the lowest life expectancy of any group. Some people even say, well, how do we figure out what racism is? How do we define racism? And some scholars say, well, just look at life expectancy, because lower life expectancy for a group of people, not for any individual, but for a group of people, a lower life expectancy often represents the force of racial discrimination against them. Okay. But if we looked at the healthcare system per se, geez, let's see that. All right. I guess I'm gonna make you disappear again so you can see the end of this. Oh, that didn't work. Here. There we go. All right. I tried to make you disappear and made everything disappear. We're looking at is the number of doctor visits for white persons versus Black persons in the US, and it continues. You can see the separation in the earlier years, and behind your photographs, there's been some continued separation. I'm actually expecting that to get significantly worse under the Trump regime because of the cuts to Medicaid and sort of the outlawing of even discussion of racial differences in any federally funded research or federal publications. But for some time, it's been true that outpatient visits, the routine care that people rely on to help them stay healthy, has been much more available to the white population than to the US Black population. This is looking at Black serving hospitals versus all other US hospitals, and the Black serving populations are presented in blue and the other hospitals in yellow. And this is actually looking at some work looking at for all hospitals in the United States. Black serving hospitals were those that were defined as the 10% that saw the most Black patients. So on average, they saw, I think, about 45% Black patients. The other 90% of hospitals, saw a lot fewer patients, averaging about 5% of their patients. So the Black serving hospitals as a group, the 10% of US hospitals that are Black serving, receive much less reimbursement per day, an average of only $7,300 per day versus $13,000 per day in, I guess it was 2017 dollars. Nonetheless, the Black serving hospitals tended to run fairly efficiently. Nonetheless, they did generate a loss, an average loss of $170 per patient day, versus the white serving hospitals that had an average profit of $418 per day. And I know I don't think you guys have entered your clinical years yet, but one of the things, this was actually done by two trainees that actually happened to be my daughters, but they were in medical training at the time. And one of the first things they noticed as a third and fourth year medical student, you go in these rotations. I guess now sometimes you do it at the end of second year. You go in rotations and you go to a hospital full of Black people, a hospital full of white people, and things are very different. The hospitals look different. The white serving hospitals are more spacious. There's fancy atriums, coffee bars, and the Black serving hospitals are much more crowded, much more limited in their resources. You often meet a lot of very good, dedicated health professionals there, and you can learn a lot, but it's very noticeable the differences in the amount of money available for their care. And these researchers actually went on and looked at capital, okay, how much capital the Black serving hospitals and white serving hospitals have. This data is available for Medicare through something called the Medicare cost reports. And in this case, they looked at both Black serving and Latinx serving hospitals using a similar technique of saying, if you're in the top 10% of hospitals in terms of your Hispanic share of your inpatient population, your Hispanic serving, the other 90% were not. And using this definitions, they looked at capital. Now, capital is the value of all the buildings and all the equipment in the hospital. So the size of the physical plant, the how modern it is, how luxurious the accommodations are, access to technology. That's all captured in Medicare's measure of hospital capital. So they did find that the Black and Latinx serving hospitals, in this case, that's yellow and blue, and the white serving hospitals is green. Okay. That the Latinx and Black serving hospitals had much lower existing assets, much lower existing value to their buildings and equipment, and over a 5-year period, the purchases of new buildings and equipment were significantly higher on average at the white serving hospitals than at the Latinx and Black serving hospitals. Again, just something, and this is it's per bed day. These are dollars per bed day. Obviously, if you look at the whole hospital level, it's many times that number. But the conclusion that they made, and I think you'll see this in your own training, is that the resources we as a society devote to the care of poor and minority people are just much lower than what we would devote to the care of majority and affluent folks. Okay. So many Americans get the care. They go and they get the care. They manage to get in and get care, but they have to go into debt to do it. And this is a big source of unhappiness among the electorate. It was really largely ignored for a long time. In the last 20 years or so, it's gotten more attention. We did a lot of the early work on this with Elizabeth Warren, where I was at Harvard Medical School and she was at Harvard Law School at the time. But kind of bringing to the public's attention that medical debt is a very serious issue, can result in bankruptcy. This is some more recent work that we did. It has been published in JAMA Network Open, but where we looked at a population-based study of the American population to see who was in medical debt and what happened over the next 1 to 2 years in terms of their food and housing security. So if you had medical debt, you were more than 2 times as likely to become food insecure, to be unable to pay for sufficient food. You were more than 2 times more likely to be unable to pay your rent or mortgage, to be unable to pay your utilities or be evicted, which those 3 things would all represent some degree of housing insecurity, some worse than others, obviously. So we talk a lot about social determinants of health, like food insecurity and housing insecurity. And again, you're going to hear that in your medical education. But we have to own up to the fact that the healthcare system itself can, through imposing medical debt on people, make them more likely to lose their food security and housing security. Okay. Now, all of these problems are occurring in the context of a very bureaucratized and business-oriented healthcare system in the United States. And this is some work we've been doing over the years, looking at the growth of physicians and the growth of healthcare managers. And there has been some growth in physicians over the last decades, but that's actually been dwarfed by the rate of increase in proportional increase in healthcare managers. And we've also seen some of those healthcare managers are involved in the insurance industry, but I want to emphasize that insurance overhead is only one aspect of the bureaucratic hypertrophy in American healthcare that's really robbing a lot of resources from care. This is data from the Organization for Economic Cooperation and Development, which is a data organization that affluent Western nations are members of. Actually, some Asian nations have joined as well, but it aggregates data from different countries so that we can compare them. It mostly on economic issues, but they do a substantial amount of comparisons on health-related issues as well. But this is their data on insurance overhead in the United States. relative to the insurance overhead in other countries. And this is on a per capita basis. And of course, many of these nations are just as affluent as the US is at this point in history. So, and yet they've managed to run healthcare systems with the insurance overhead just a fraction of what we pay. And that's because they either have a like fully public insurance structure or a sort of a mixed public-private, but with very, very strict constraints on what the private insurers can look like. Very strict rules about what they can charge, what they have to cover, who they cover. Something very different from, let's say, what private insurance looks like in the United States. Okay. I told you insurance overhead was just a portion of this. This is actually looking at physicians billing related expenses. I think this is from 2021. I can't quite see, but that's what it looks like, maybe 2024. But per capita in the US, it's $655 per capita. I'm not saying per physician or even per patient, but per capita, we're spending $655 on physicians overhead. In Canada, they spend less than 1/6 that amount, or about 1/6 that amount. So just running a doctor's office in the United States is extremely expensive, a lot because you're billing so many different insurance companies. You're dealing with many different formularies, different sets of prior approval and coverage rules. It just makes running an office very, very expensive in the US. And then, of course, hospital administration. There's actually very good data on this because, again, it's collected by Medicare. But this is just a comparison between Duke Medical Center and Toronto University Medical Center. And I don't think anyone said they were from North Carolina, but Duke is obviously a major medical center in North Carolina. They run 3 big hospitals, nearly 1,000 patients. Toronto University Health Network is also a big network there in Toronto, Canada, with 1,300 beds and 5 hospitals. But Duke Medical Center employs 1,600 billing clerks, which I think is, almost 2 per bed. Toronto University Health Network employs 7 billing clerks. And those billing clerks are there to bill for things like TV sets, and also to send bills to Americans who get sick when they're in Toronto and need to have a bill sent. And that's because a Canadian hospital does not send bills to patients for hospital care. So a Canadian hospital, no Canadians can go to any hospital in Canada, and their health care is free. Your covered services are all free. And that's very nice for the patients when they get sick and go to the hospital. They never have to worry about the bill. But it's also nice for the hospital itself that it doesn't have to have that kind of bureaucracy of keeping track of everyone's insurance and getting bills to the individual patients. Hospitals in Canada are paid on a globally budgeted basis. So global budget as defined in Canada is just, let's say, the way your local fire department is budgeted in the city where you live. The local fire department gets a budget every year. 1/12 of that budget is deposited in their bank account every month. And that's how they run. And if there's a problem and they need more, they go and they lobby and give us more money and, whatever. But it's always as part of a global budget. It's not on a per case basis. And that's a more efficient way to pay for a hospital. It makes them easier to administer. It allows the hospital administration to focus on good patient care and not just collecting money. Okay. Anyway, when we break this down and compare on a per capita basis, hospital billing and administration in the United States and Canada, per capita billing and administration in the US is $1,200. In Canada, it's $217. And if you just look at how complicated billing and administration is in the US, you'll understand why billing costs so much. If we have about 240 health insurance firms there's over 300,000 individual plans, 600,000 billing codes for healthcare products and services, and you do out the math there, and it comes out to, I guess that's 56 billion negotiated prices. It's a ridiculous amount of complexity just to get paid. Okay. We shouldn't be surprised to know that healthcare costs as a share of GDP, represented in blue, have risen much faster than in Canada. But we also, I should tell you that Canada implemented a national health program at the same time that the United States implemented Medicare and Medicaid. And a lot of that difference, about half of the total cost difference on a per capita basis, is the cost of bureaucracy and the excess of paperwork in the United States relative to Canada. The rest has to do with capital controls on over investment in capital, but I don't think we're going to go into that much today. If we look on a per capita basis at what's being spent, I think I told you we're spending more than 14,000 per capita in the United States versus those other figures in other countries. In the blue at the top, I've graphed total spending in other countries. But for US spending, I broke it down into taxpayer-supported spending in yellow and private spending in orange. And I do want you to look at where that yellow line ends. That is, tax-supported health spending in the United States exceeds total health spending in other countries on healthcare. And then after we pay all those taxes for healthcare, we go on and take additional money out of our pockets and pay privately. It's a very, very expensive and very wasteful system. We think of it as mixed public-private, but there has been a real shrinkage of people who have private coverage in the United States, falling from 85% of the population to I think we're showing about 65% of the population with private coverage. Okay. At the same time, we've seen a privatization of the public coverage. So we all think of Medicaid as public coverage. It's a healthcare program, the joint federal state program that covers the poor. We're all thinking, oh, well, that's public. It's been around since 1965. But recently, Medicaid has been increasingly funneled through private insurers, private managed care insurers, with the majority of the Medicaid population recently has been enrolled in managed care plans. Only a minority remain in a fully public program. Similarly, Medicare enrollment, let's get over there. Medicare enrollment has been Medicare HMO enrollment. So Medicare HMOs are also known as Medicare Advantage. And these are private managed care plans that get a set premium from the taxpayers and then manage the care for Medicare recipients. And enrollment in that program has soared and now is above 50% of all Medicare enrollees are in a private managed care plan. What this has meant for the private insurance industry is that now they get the majority of their revenues from Medicare and Medicaid. So I think we're having trouble seeing the labels here. Okay. Okay, so private insurance is blue, Medicaid is yellow, and the gray is Medicare. And as a share of the revenues, Medicare has been rising. And currently, United Healthcare gets the majority of its total revenues from Medicare and Medicaid. 3/4 of its revenues are Medicare and Medicaid. And United Healthcare, I'm going to talk about a fair amount. They're one of the big three private insurance companies. In fact, they're by far the largest private insurance company in the United States, but this is also true of other large insurers. Okay, this is the overhead and profit per enrollee. In private insurance and in traditional Medicare. So this is employer sponsored. coverage, that has about $826 overhead per insured person. Medicaid has something similar, $700. Traditional Medicare, the lowest overhead of all, in yellow, $226. But then Medicare Advantage, the privatized Medicare programs, $2,000 in overhead per enrollee. That's really a lot of money. This is despite the fact that Medicare Advantage enrollees tend to be less sick, to cost less than those in traditional Medicare. So this was a Kaiser study that looked at the previous people who were in Medicare, and some of them switched to Medicare Advantage, what had been their previous year use of medical care, and they actually compared them in groups, look at just diabetics or look at just people with heart failure, and compared the use in the year prior to enrollment in Medicare Advantage, and we're able to see that Medicare Advantage was selectively enrolling people who used less care. So in the years they looked at, those who stayed in public Medicare had more than $1,000 more in medical expenditures the prior year, indicating that Medicare Advantage was selectively enrolling lower cost recipients, beneficiaries. In addition to selectively enrolling healthier people, the Medicare Advantage plans do eject patients requiring expensive care. And here the percent switching from Medicare Advantage to back to traditional Medicare. So you can leave Medicare Advantage, go back to traditional Medicare. And folks who used a hospital stay in blue were much more likely to switch back than those who hadn't been in the hospital. Those who were in a nursing home for rehab were much more likely to switch back to traditional Medicare than others. And those who had any home care use were nearly twice as likely to switch back. So that sicker folks were switching back out of the private plans back into fully public Medicare. Are Medicare Advantage plans actively pushing people out? We do think that's likely true. I think one mechanism is by imposing 20% co-insurance on expensive medications like chemotherapy. So 20% is the highest that Medicare will allow the Medicare Advantage plans to charge. But currently, essentially all of Medicare Advantage plans charge the full 20% co-insurance for cancer chemo. And cancer chemo can be very expensive. I think on average it's about $100,000 a year for a new cancer drug. Some drugs are as high as $1 million a year. So if you're stuck with a 20% coinsurance, that's a very big deal. It means every single year you're spending all the way up to your out-of-pocket maximum. Okay. We also know that for very sick patients, not the average patient, but for very sick patients, Medicare Advantage offers inferior care. The data on the average patient is kind of mixed, but when we look at a very sick group, and this was cancer patients requiring complex surgeries, like esophageal surgery, something you really need a specialized center to get. Pancreatic surgery, liver surgery, stomach surgery. You'll learn about these, maybe you have already, but they tend to be very surgically complex conditions. But relative to patients in traditional Medicare, those in Medicare Advantage were much less likely to be seen at a teaching hospital, represented by the adjusted risk ratio less than 1. They were much less likely to get their care at a National Cancer Institute cancer center. They were much less likely to go to a high volume surgical center. They were much more likely to have delays in receiving their surgery, and they had much higher 30-day mortality. So for very sick patients who require very expensive care, there's substantial evidence that quality of care is lower in the Medicare Advantage program. And of course, Medicare Advantage plans routinely deny needed care that should be covered to tens of thousands of people a year. That the federal government knows that. You probably know that too. Meanwhile, the Medicare Advantage programs use are using upcoding to boost the payments they receive from the taxpayers. The taxpayers' payments are adjusted for the patient's risk, but the patient's risk is determined from diagnoses that the Medicare Advantage plans themselves submit to the federal government. And you can really manipulate that system through upcoding just by changing what you write on the chart from obesity to morbid obesity, or from type 2 diabetes to type 2 diabetes retinopathy, major depression to major episode with single episode mild. Just by changing the documentation, you can upcode. This is the same patient described two different ways. You could get as little as $9,000 a year for that patient, or as much as $32,000 for that patient, depending on how effective you were at upcoding. I'm going to skip that. Okay. They've used a lot of mechanisms to upcode, and I don't want to spend that much time on that. I suspect you've heard about it from some of your other speakers. But the upshot is that Medicare Advantage is costing the taxpayers substantially more than traditional Medicare. That's represented by that right-hand bar being higher. But in fact, when you look at the amount of care received, the amount of money the Medicare Advantage actually paid for doctors or nurses or drugs or visits, whatever, hospitals, the amount of care received was actually greater in traditional Medicare, despite its lower overall cost. The difference was made up by the very high overhead of the Medicare Advantage programs, which we've talked about. There's also been a new scam, which involves a Medicare Advantage marketing to people who are already enrolled in the Veterans Administration. Veterans Administration provides free or low-cost care to qualifying veterans. So they're going out and marketing to veterans, and we have a special plan for you. Come join us. We'll have special veterans benefits, knowing full well that many of those patients will go out and get their care from the VA, and the government ends up paying twice, once for the premium to Medicare Advantage and a second time for their care in the VA. Okay, this is actually private, Medicare paid private plans, over 600 billion more than enrollees would have cost in traditional Medicare. This is some work we published in JAMA Internal Medicine, but this just looks at the data on overpayments, which have been put together by something called MedPAC. It's the official congressional watchdog agency of the Medicare program. Using MedPAC numbers, we looked at, and numbers from the Medicare Trustees Report, we looked at Medicare overpayments to Medicare Advantage plans and the overhead of Medicare Advantage plans. And turns out, of the 600+ billion that's been overpaid to the Medicare Advantage plans, the majority of it just went into their overhead and profit. And that's not surprising based on what I've told you. Okay, so I want to get to our final topic, which is financialization and the question of who should own U.S. healthcare. And I guess a subsidiary question is, what goals should drive decisions? The model that's now emerging in the United States, I'm calling it the ascending model, is that investors are coming to own U.S. healthcare, and their only goal is financial gain. And of course, that's what you expect if you buy stocks in the stock market or try to save money for something. You want the investors to get money for you. But that's the ascending model, is that you've got to have investors whose only goal really is financial gain. In a bygone era, doctors and nonprofit hospitals kind of controlled healthcare, and they had a mix of goals. I mean, there was altruism. You did care about patient health, because in fact, you've got to be a real scoundrel if you see a sick person and you don't care. And most doctors, except the scoundrels, do actually care about the patient in front of them. Okay. But also professional and social norms, the desire to be seen as a good doctor. And, let's be honest, financial gain, that was a goal. People work in medicine to earn some money. that that's not your only goal, but that bygone era is actually gone, and we've moved into this new era. And what I'd like to see is an era where patients, caregivers, and communities just control healthcare, and their goal is population health. That's what we ought to be working for through our political advocacy and our research. Okay. Well, just looking at the extent of current for-profit ownership, for-profit ownership is actually very high, except in the general hospital sector. So general hospitals, that's most of the acute care hospitals where you guys are going to train, by and large have remained at least nominally nonprofit. Lots of people make money off of them, the suppliers, the real estate interests, but the hospital itself continues to be run on a nonprofit basis in 88% of the cases. 12% of those general hospitals are for profit. But in some areas like long-term care, it's really getting close to 100% is run on a for-profit basis. Just looking briefly at the drug industry, they're actually making the largest profits of any healthcare sector, massive profits, and their profits are 2 to 3 times as high as the average Fortune 500 company. And Fortune 500 revenues are very high and profits are very high in the Fortune 500. And yet drug companies year after year after year have been making profits 2 to 3 times higher. Pharma has done tremendous profiteering off of diabetes drugs. The cost to produce is, at most, for most of them, around $1 or $2. Some of them are as much, as semaglutide's $38 an injection, but the injections you only get once a week. So there's really been a lot of profiteering with a low cost of production and very high sales price. Okay. For-profit hospitals are known to avoid vital but unprofitable services. So if we look at what differences we can find between for-profit and nonprofit hospitals, this is the big one. The government and nonprofit hospitals more often offer unprofitable services like HIV care, substance use care, outpatient psychiatry, hospice, and palliative care. Whereas the for-profits don't like to offer those because they can't make a profit. We've seen, as I mentioned, long-term care going for-profit at a very fast rate, including hospice care, which is like the craziest idea ever. Why would you think a dying person should be cared for on a for-profit basis? They're not going to be able to defend their own interests or be a smart consumer, but in fact, we've gone that way in the United States. There is substantial evidence that for-profit hospitals minimize care and maximize their payments. I've listed some of the evidence about what they do, but suffice it to say that the way that hospice is paid, it's primarily from Medicare, makes it more profitable to work in certain ways, to offer a narrower range of service, to have less skilled staff, to choose patients who don't need much care, and there's substantial evidence that they reduce the quality of care. So it's frankly just a crazy idea to run hospice on a for-profit basis. But I want to talk a little bit about the newest player in this, which is private equity. And I'm not sure how familiar people are with private equity. Have you guys heard anything about private equity in this group?
We did receive one lecture about private equity.
Okay, so you know something about it, which is probably more than most medical students. All right, certainly more than I knew when I was at your stage of learning. But private equity, is private equity is giant group, amounts of money, but private equity firms don't sell stock on the stock exchange. So if you're on the stock exchange, you have a lot of regulations from the Securities and Exchange Commission, including a lot of disclosure regulations. Private equity can move very fast and they don't have to disclose very much. So they're able to be much more aggressive in their pursuit of profits than even our traditional for-profit firms that sell stock on the stock exchange. So there's been you probably saw this before, there's been a tremendous increase in interest in healthcare in the private equity world. Currently, private equity holds a lot of medical resources, but they tend to focus on things they think they can make money on. So 1,300 women's health practices. They're primarily fertility clinics, which is mostly private pay, and it's very, very lucrative. You can charge almost whatever you want because you know, people are really, really want kids sometimes in a fertility situation. They own 8% of hospices, 8% of dermatologists, 7% of gastroenterologists. Very high penetration in medical and radiation oncology. I guess they see those as profitable. Lots of anesthesiologists and hospitals, nursing homes. They also control one single firm. Staffing firm controls 25,000 ER docs and other like physician's assistants and nurse practitioners who work in emergency departments. So entering into the actual business of running physicians' practices has also been a big focus of private equity investment. Did you guys hear about Steward in your last lecture? I'll just review it for you, but Steward Hospitals was a nightmare. We're still in the middle of it in Massachusetts. Now everyone's saying Steward pillaged healthcare, private equity firm, and hospital landlord contributed to this giant bankruptcy. And this is more about the bankruptcy. In fact, the state of Massachusetts is going to have to come up with at least $500 million, maybe an entire $1 billion just to keep critical hospitals in the Boston area open. The story behind this is that there was a system called Corrigus Christi, which was owned by the Archdiocese in Boston, and it was a pretty good system. They provided a substantial amount of safety net care through their affiliated hospitals. It was 6, and then it was 9 facilities. It was purchased by a private equity firm, which promised to do all sorts of community benefits. Once they had purchased it, the firm stopped doing the community benefits. It sold off the assets and ended in bankruptcy at the same time that the CEO was buying luxury yachts. This is a picture of his yacht. Issuing new mission statements like the company's organized for the purpose of engaging in investment, trading, or financing activities of all kinds. Getting rid of its old mission statement, which had to do with scientific research, patient care, promoting the general health of the community. That got discarded. But it was quite a debacle. The hospitals were driven into bankruptcy by the CEO. They had to be bailed out by the state, and several of them closed permanently. And patient care really suffered. The hospitals were running out of staff. They were running out of supplies. The elevators were all broken. Meanwhile, the investors ran off with hundreds and hundreds of millions of dollars of the hospital's money. But it turns out that this was not an isolated incident. When people have looked at systematically at quality of care after private equity buys a hospital, they do find much more in the way of hospital-acquired infections, falls, central line infections, and surgical site infections, and just showing the percentage increase in these complications after private equity acquisition. And this was some work we did looking at the ways that private equity strips capital and assets from hospitals. They typically will buy a hospital and sell off the real estate out from under them, forcing the hospital to rent back a facility it once owned out of its operating budget. But private equity routinely strips capital and assets from the hospitals it purchases. This appeared in JAMA fairly recently, looking at the time all the private equity acquisitions in the United States. But you'll see the amount of capital they had prior to private equity acquisition was similar, but after private equity acquisition, there's a big drop in the capital assets off in the real estate that the hospital has. Okay. So this just walk through what happened. This is actually private equity acquisition of a nursing home chain. It was the second largest nursing home chain I guess I've got these things popping up here. In 2007, the Carlyle Group, a private equity firm, bought Manor Care for $6.1 billion in a leveraged buyout, with the nursing homes, not Carlyle, responsible for the debt. It sold off the real estate for the same amount of money they paid, and it paid off the investors and saddled the nursing homes with $472 million in annual rent payments. Between 2013 and 2017, they had layoffs, cost cutting, and soaring quality violations documented by inspectors. And in 2018, the real estate chain filed for bankruptcies, and CEO walked off with $117 million in deferred compensation. Essentially the same story as what happened with the Stewart chain. And again, this is sort of systematic. It's not just one chain, but when people look overall at private equity acquisition of nursing homes, they find that quality deteriorates. What are these? Mortality rate goes up, antipsychotic prescriptions go up, staffing falls, nurse aid staffing falls, but cost to the taxpayers actually rise. This is just physician practice acquisitions. I'm not going to go through the details here because I want to leave a little time for discussion, but private equity has been buying up physician practices. They generally try to monopolize all of one type of specialty in an area, like they might own all the derm practices in an area. Then they can push up the prices that they charge and make a lot of money. And this is just evidence. Again, I'm not going to go through it, but when private equity buys a practice, the prices rise, represented by the green lines for gastroenterology, dermatology, OBGYN, and ophthalmology. Okay. I'm a primary care doctor by training, so I was very interested in the growth of for-profit primary care startups. There are many of these that are high-touch care with a lot of wellness benefits, and they use the high-touch care, frequent phone calls, frequent visits to recruit patients and focus on Medicare. The primary care doctors then do intensive upcoding. Examples would be unnecessary screening ultrasounds, blood tests to just overdiagnose patients. Some of these firms have been offering primary care doctors $30 per visit bonus just for using upcoding software to write their notes. Oak Street Medical gives their primary care doctors a scribe specially trained in how to upcode, who actually writes the note. So they upcode and upcode and upcode, get more money out of Medicare. And the end game is they will almost certainly sell to private insurers who use these practices to boost profits and raise their own overhead and profits and launder it. They launder it by saying, well, we actually paid that to Oak Street Medical. It wasn't insurance overhead. It was just medical payments. So just to walk you through an example of this, we've seen the emergence of United Healthcare as really an empire, a mega corporation, a giant, consolidated healthcare corporation. The United Health Group not only owns United Healthcare, which is the largest insurer in the nation, through its Optum division, it employs over 90,000 U.S. physicians. It's about 10% of all practicing physicians. They have a giant consulting and analytics arm. They caused a giant problem when their Change Healthcare Analytics software got hacked and they couldn't pay doctors for 2 months. And then they own, through their Optum RX, own a giant pharmaceutical benefit management firm and a mail order pharmacy. So a giant firm that participates in all levels of the healthcare system. I'm sure you heard about their CEO getting murdered in cold blood on the street in New York. Nothing that I'd ever advocate, but I did not get any sympathy on social media. People are very, very angry at them. And this, I saw a t-shirt for sale in Venice Beach, California. Luigi was the man who actually murdered the CEO. And again, I'm not advocating violence, but I'm just saying that this gives you some idea of the depth of dissatisfaction that Americans have with the way healthcare is going. There's other giants like CVS, Aetna. They're actually just similar in size to United Healthcare, but they have a similar strategy. They actually started with bricks and mortar pharmacies. They went to a giant pharmaceutical benefit manager and mail order pharmacy. They purchased a big insurance company in 2018 to have an integrated insurance health delivery product. They started minute clinics in many CVS stores. I think those are not doing very well. So they purchased a giant primary care network called Oak Street Health. I talked about them earlier. They had 169 clinics when they were purchased, but CVS has been opening about one new clinic a week. So they're trying to turn into one of these giant integrated organizations, insurance, doctor care, pharmacy care, and optimize their profits. And of course, even bigger players like Amazon have entered the fray. Amazon purchased One Medical, which is all over the place as like a primary care provider. It's you pay a subscription fee of a couple $100 a year, and then they bill your insurance. Okay. We've seen a situation in which most physicians are now corporate employees, and as recently as 2019, a very large share of physicians were non-corporate, but there's been a tremendous growth in both hospital employment and employment by giant corporations, and a substantial shrinkage in the share of all U.S. physicians who are in any sort of non-corporate, non-employee setting. Now, I've talked a lot about for-profits, but I want to remind you that our nonprofits have been financialized as well. And obviously, Mayo Clinic is a giant nonprofit with revenues of $13 billion, but they're only providing $78 million in charity care. They only see 3% Medicaid patients. They have massive profits, almost 10 times as high as their total charity care. They purchased private equity assets of $3 billion, and they have a total endowment of $11 billion. So they may be a nonprofit, but they're not actually providing much to the community in terms of community service. Many nonprofit health systems are going out and buying private equity. Private equity involvements are in the billions. That's the second from the last column. Hedge fund investments, total investments. They're giant financial actors in addition to whatever they're doing in terms of healthcare. Additionally, our nonprofits have been known to sue patients who can't pay. This is Johns Hopkins Hospital, obviously a major academic center. And they were suing their patients. And then the union there said, well, let's go look at the court records and see whose wages they're garnishing. When you sue patients, often the courts will say you can garnish their wages, take part of the money out of their wages. Who was employing the people whose wages they garnished? It turned out the top two employers were Johns Hopkins University and Johns Hopkins Hospital. So Johns Hopkins was literally taking patients to court, suing them and garnishing their wages, and those patients were being employed at that time, were employed at the hospital itself. Pretty outrageous behavior for an entity that calls itself a nonprofit. So financialization means that money is now the mission. Traditionally, providers invested money in buildings and equipment to produce more medical care, and produce more medical care was our service mission. And now financial entities invest in medical care to produce more money, that is profit, and then money is the mission. So that's the problem we're up against here, and why many of us have come to believe that we need to really change the ownership of healthcare. It's not going to be enough to get Medicare for all and just have one government entity paying all the bills. That's necessary. That's the idea behind single payer. That's necessary, but it's not sufficient. We do need to be talking about who owns healthcare and how healthcare is controlled, not just how it's paid for. Julian Tudorhart, the late great British GP, once said the availability of good medical care tends to vary inversely with the need in the population served. This inverse care law operates more completely where medical care is most exposed to market forces, and less so where such exposure is reduced. And he said the market distribution of medical care is a primitive and historically outdated social form, and any return to it would further exaggerate the maldistribution of medical resources. I think we have returned to it in the United States, and we're going to see massive expense and maldistribution of resources. So I'm going to stop my share and we got a few minutes for questions. I'm sorry we don't have longer, but any comments or questions?
Well, first, let me just say thank you, Dr. Woolhandler. I think all of the graphics that you used were very helpful for visualizing these problems. I can start us off with some questions, and I have a few, so I'm just trying to decide which one I want to start with. But I guess I was perplexed by the fact that when you were talking about Medicare Advantage and how enrollees are actually healthier, maybe because of some sort of cherry picking, but you had a slide that shows the cost per enrollee. So if Medicare Advantage patients are healthier, why are they enrollees? I don't know if costing is the right word, but you had the slide that said they were like the bar was like $2,000 for these kinds of patients. So I guess I was a little confused.
Yeah, it's very confusing because there's the cost to the taxpayer, and the cost to the taxpayers is the premium that CMS, the agency that runs the Medicare, that the premium that CMS gives to the Medicare Advantage plan. That's the cost to the taxpayers. And that is substantially higher for Medicare Advantage enrollees than it would be if those same people had stayed in traditional Medicare. That's a piece that's higher. Once they get into Medicare Advantage, what happens to the money? Well, a certain share of it goes to pay for medical care, and another share of it goes for overhead and profit. And because the overhead and profit is so large, the actual money they're spending on medical care is less. And part of it is the managed care restrictions. They tell you can't get the care, or you have to go to this cheaper doctor or cheaper hospital. So that's part of it. But part of it is what you were saying, cherry picking. They've selectively recruited people who, for whatever reason, have a propensity to use less care. So I think one group that's true of is, for instance, Hispanic people. Just as a group, they use less care, and maybe it's traditional or whatever, but they do. Lower income people actually, once you correct for their different health status, lower income people use less care as well. People who struggle to pay the co-payments also use less care because they just avoid care. So you can identify people who have a propensity to use less care and then selectively enroll them. And you get a big, nice fat premium from Medicare based on the number of diagnoses you list. But these people are just the type of folks, for whatever reason, who don't use care.
Thank you. That helps. Zachary?
I know you ended the presentation speaking about like financialization is pervasive through all aspects of healthcare delivery, including nonprofits. And typically I've been privy to, having the public health insurance with a single payer status and maintaining private ownership of like hospitals and potentially having them all maintain their nonprofit status and excluding for-profit hospitals, maybe through like forced acquisitions or something like that. Do you think that, and I know nonprofit hospitals they recently have monopolized and like largely consolidated markets. Do you think that if with my suggestion of just maintaining nonprofit ownership and public ownership of hospitals, that even with the implementation of a single payer system, they would be able to reform themselves enough to kind of move away from that financialization aspect of their business model? Or do you think that there's no amount of reform, or how optimistic are you that they'll be able to reform and become less like revenue or profit driven?
Well, I think when you're talking about a nonprofit institution, there's at least a potential of really strict regulation on them and getting them to behave, right? I think that's possible. I think when you start talking about private equity and for-profit corporations, you just can't come up with regulations tight enough to get them to behave. And I think we've seen there's been efforts to regulate for-profits. They're pretty desultory, but there have been some, and they haven't succeeded. So I don't think we should have any for-profit organizations involved in any sort of delivery of care, direct patient care situation. I think nonprofits, I think if they're tightly enough regulated, you might be able to make that work. So I personally think, well, and there's one situation where that's not true, and that's a situation in which you have one hospital or one hospital system that's regionally dominant. And then they're really running the show in that town, a regionally dominant hospital. And I think when you have a regionally dominant hospital, you're going to have to think about public ownership because they just have too much power to raise prices. But good question. Terrace, did you have a question?
I think Anana raised her hand first, actually.
Oh, and not, okay, fine, that'd be fine.
Thank you. I had a clarifying question. So, when we were talking about Medicare Advantage earlier on in the internship, we talked about, I just remember this because it shocked me so much, but about the deceptive marketing to kind of get patients and especially elderly patients that were thinking that they were going to sign up for traditional Medicare ended up signing up or filling out little flyers for Medicare Advantage. And then once they were in Medicare Advantage plans, that they were essentially trapped. But and maybe I understood what you were saying, but in your talk, you said that some patients could go back into traditional Medicare. Is that true?
Yeah, you can. The way people get trapped, you can leave. You have to stay in for a year now, but you can leave. The problem is there's Medigap insurance, and that's this private insurance that people buy to cover the things that Medicare doesn't cover. And if you sign up for Medigap when you first become eligible for Medicare, it's a pretty low premium, you know. But if you sign up later, if you've been in a Medicare Advantage plan and you want to come back out and get a Medigap policy, there's no cap on how much they can charge. So they can charge you a huge amount of money for your Medigap. So say you found you had pancreatic cancer, go to get Medigap, it's going to be, you'll never be, I mean, the Medigap's exorbitant, cost of your care is exorbitant. Yeah, there's actually not going to be insurance available to you. So that's by and large the way people get trapped. If you decide to leave, you know, before that kind of before you get a very high cost illness, or you have some other way to pay for Medigap, or you just decide to go without Medigap, you can leave. You know, people do leave because they just can't get the care they need. Less of an issue if you have both Medicare and Medicaid, so-called dual eligibles, because Medicaid provides the equivalent of Medigap coverage for at least some Medicare dual eligible folks. Yeah. Theris, do you have a question?
Yeah. So this is not like specific to your talk per se, but I was just wondering, as a longtime single payer activist, like how has the movement evolved over time and how do you expect it to continue to change in the more recent future? And I guess I'm like particularly interested in like movement strategy and also like your own personal views.
Well, okay. What's going on right now is I think everybody's very focused on the changes that Trump is making, both because they're really threatening to the entire healthcare system and because they're threatening to American democracy. So, you know, we have to like think about it in the context of what's going on the rest of the society. I do think we need to be continuing to propose Medicare for all, because the patients are very dissatisfied with the cost of care and the restrictions on their care. I think in terms of talking to doctors and nurses, we need to be talking much more about ownership and how we're going to reform the actual ownership of health institutions, because doctors and nurses often feel like the person oppressing them is their own hospital administration. So I've been very supportive of the unionization movement, which has been ongoing for some time among nurses. There's been a big growth of the unionization movement among physicians, led really by house officers unions, but recently some of the attending physicians and staff physicians have been unionizing as well. So I think we need to be talking about ownership. We need to be thinking about things like unionization in addition to the sort of professional organizations that we're members of. Um, I think we need to be putting ourselves in the context of the larger threats to the healthcare, to health and healthcare and democracy that the Trump administration poses to us.